Okay, shall we start? So just for you to know where you are, we are at the Bellflower, the WaSH intervention session. So I usually remind everyone because I usually get in the wrong room, so I only find out after the first presentation starts. So with so many flower names here, tree names here, it's very easy to get confused. So let's start with Viviana Albán from University of Washington. She's going to present the effectiveness of the PAASIM, piped drinking water intervention for reducing children's enteric disease across different seasons in meteorological conditions. Viviana.
Thank you. Good afternoon, everybody. I'm Viviana Albán. I'm a graduate student at the University of Washington, and today I'm going to be presenting this research titled Season and Heavy Rainfall Events as Modifiers of the Effectiveness of a Piped Drinking Water Intervention for Reducing Children's Enteric Infections. And this is a study from the PAASIM project in Beira, Mozambique. I want to acknowledge that this research was conducted by Rebecca Khan as part of her dissertation work. Unfortunately, she couldn't be able to be here in person, so I'm presenting on her behalf. Rebecca is going to be on Zoom, so if there are any questions on Zoom, she can answer. But she's also on the phone because she really wanted to be here. So if you have any questions, she's going to be able to, get back to you. But also, you can reach to her directly via email. So that's her email address if you need to. Okay, as an introduction, diarrheal diseases is responsible for over 400,000 deaths in children annually, making it the third leading cause of death among children under 5. Diarrheal diseases are also treatable and preventable, and in fact, 35% of diarrheal diseases in low and middle income countries are caused or can be attributed to unsafe drinking water. This analysis uses data from the PAASIM study, which translated to English means research on access to water and children's health in Mozambique. Here is the theory of change for the PAASIM study, which is testing if and how improvements in water supply in urban areas in Beira, Mozambique reduce or delay enteric pathogen infections and other health outcomes in infants. And specifically, the intervention in Beira was a World Bank funded intervention that aimed to improve piped water supply in urban areas. This intervention included several components, but most notably the piped water distribution system was upgraded and expanded in targeted neighborhoods across Beira. So on the right, you can see some of the pictures of the construction that was happening in the study area. And this is showing a summary of the key main results from the PAASIM study, where boxes in green or teal represents outcomes that favor the intervention, and non-colored boxes represent no direction of the effect. So in short, what they found is that people who lived in the intervention neighborhoods have had more direct household connections to the piped water systems in comparison to the comparison neighborhoods. There was some impact of the intervention on gastrointestinal conditions. Specifically, there was some impact on reducing the number of co-infections, fewer concurrent infections, and specifically also some evidence on the impact of cryptosporidium. However, as you can see in this slide, there was evidence of diminishing the effect of the intervention as we go farther down the theory of change. And these null results raise follow-up questions to the study as why we are not observing these health impacts despite the observed improvements in water access. And one potential hypothesis is that both the drinking water access and enteric pathogens outcomes vary by season. So this slide is showing a table with the results from a systematic and meta-analysis that assessed over 50 different WaSH interventions and showed that overall WaSH interventions were more effective for reducing diarrhea in the dry season compared to the rainy season. Another study reassessing the WaSH-B interventions found that nearly all WaSH conditions also varied by season and by specific weather conditions, including heavy rainfall events. So to address this question within the context of the PAASIM study, this analysis examined how seasonality and heavy rainfall events impact the effectiveness of this PAASIM drinking water intervention. So this study used data from 600 12-month-old children enrolled in the PAASIM study cohort with data collected between February 2022 to November 2023. Data for this analysis came from household surveys as well as stool samples collected for each child, which were analyzed for the presence of enteric pathogens through Tachman array cards, which can tell you simultaneously different bacterial, viral, or parasitic pathogens if they are present in the samples. This study focused on 4 pre-specified primary outcomes of interest, including any bacterial or protozoan infections, any co-infections, total number of concurrent infections, and cryptosporidium infections. And these outcomes were all selected because they were identified to be relevant outcomes for waterborne enteric pathogen transmission in the study, based on the main results from the PAASIM cohort study, and also because they were important in the water quality testing of the area. So this analysis used modified Poisson to estimate risk ratios for binary outcomes and linear models to estimate beta coefficients for continuous outcomes. And they also used generalized estimating equations for clustering at the sub-neighborhood level. And specifically, so this analysis is assessing whether the relationship between living in an intervention neighborhood and enteric infection outcomes differ by season and by heavy rainfall events. And here, season was classified as dry or rainy, and the heavy rainfall events were defined as any single daily rainfall event exceeding the 90th percentile of all daily rainfall events during the whole study period. And daily temperatures and precipitation data were obtained from a weather station that was located about 7 kilometers away from the study area. This figure is summarizing the daily mean temperatures shown as black dots and total rainfall shown with the dark blue lines throughout the study period. So the distinction between the rainy and the dry season was estimated using a PCA clustering approach that incorporated data on temperature, precipitation, and humidity. So as you can see here, the rainy season corresponded to higher rainfall and warmer temperatures, whereas the dry season corresponded to lower rainfall and cooler temperatures. As a summary of the enteric pathogens outcomes, overall there was a high prevalence of enteric infections, particularly for bacterial and protozoan infections, which were detected in about 84% of children at 12 months. Approximately 61% of children had a co-infection, and 15% of children had cryptosporidium detected in their stools. Here is the regression results showing the effect of the intervention on enteric infection outcomes stratified by season. So the blue point estimates represent effects during the rainy season, and the red points estimates the effects during the dry season. So as you can see, the estimates of the two seasons are quite similar, and this pattern is consistent across all enteric pathogen outcomes. So overall, we can say that the assessment of interaction by season provided no evidence of effect modification, suggesting that the intervention had similar levels of effectiveness in both rainy and dry seasons. There was, however, some evidence of differences in the effectiveness of the intervention by the presence of heavy rainfall events. So for these models, they use 3 different lag periods, heavy rainfall events of 0 to 1, 1 to 2, and 2 to 3 weeks before stool sample collection. And here the estimates in blue are the effect of the intervention following a heavy rainfall event, and estimates in orange are the effect of the intervention where there were no preceding heavy rainfall events. And here, as we can see, there was evidence that the intervention was more protective for our primary outcomes of interest following heavy rainfall events at the closest lag period, so from 0 to 1 weeks. The same was true for antibacterial and protozoan infection and co-infections at the 2 to 3 week lag period. So this suggests that people who lived in the intervention neighborhoods may have conferred some additional benefit from being connected to the improved pipe water system following heavy rainfall events, which are periods of higher than normal exposure risks. Also, there was no difference in the effectiveness of the intervention in the 1 to 2 weeks lag period, which was hypothesized to be actually a key exposure period for timing of observing enteric infections. And there's a couple of hypotheses that the authors are thinking about this result, but one plausible explanation is that the water utility reported shutting off the main water source during heavy rainfall events. So therefore, this might be diminishing the benefit of access to the water source at these key points of exposure. So to summarize, in this analysis, there was no evidence of a difference in effectiveness of the PAASIM intervention by season, but there was some evidence of a protective effect of the intervention following heavy rainfall events. And this analysis showed that pipe water systems in urban settings may help mitigate health risks associated with extreme weather conditions. There was a couple of strengths to this study. First, the study used data on enteric pathogen detection in stool, which is a more objective and less biased health outcome measure compared to reported diarrhea. And additionally, the PAASIM study represents a unique context compared to previous research in that it was conducted in an urban setting with a pipe drinking water system. However, there were also some key limitations for this research. So first, while detection on enteric pathogens, yes, in many ways it's an improvement to reported diarrhea, it has still some limitations. So the first one is that detection in stool does not equals active infection, right? There's a variation in pathogen persistent in the gut that may play a role in active or inactive infection. And then also, this study only uses 1 sample per child. This study was conducted also following a major cyclone Idai, and then also COVID-19 hit. So they might be impacted, the pathogen transmission might be impacted in a way that it would be different than under normal circumstances. So with this, we want to thank you, all the study partners, the study participants, the study funders that made the PAASIM study possible. And now we can take any questions. I know Becky is on the phone, so if you have any questions, she'll be able to answer. Maybe I'll be able to answer. And Drew is also here, who has done a lot of work in Mozambique. But if not, feel free to email Becky too. And here are a lot of papers regarding the PAASIM project that you can scan. So we have just time for one question, please. Somebody has one? Yes.
I know a strength of this study was that you guys looked at actual stool samples and didn't ask for self-reported data, but did you also ask for self-reported data?
Yes.
And what did that look
Yes, they did. I know they have a comparison between what they found with the tag data and also reported diarrhea. But I think that's included in the, what do you call it? like supplemental material of this study. And I don't know what the results were there, but maybe Becky knows. Becky, do you know? I don't know if you can hear.
She probably didn't hear Mary's question.
There we go. She's on Zoom. So it's working. Yeah. Yeah, we can hear you.
You can hear me? Okay. Yes, we did look at the comparison with reported diarrhea, and we didn't see the same, we didn't see evidence of a difference in effects for diarrhea.
Really interesting, thanks.
Somebody else?
Methods question. So it looked like you were looking at these extreme rainfall events, but separated by season rather than all across the year. So I'm just kind of curious, why did you model it like the rain? It looked like because it was like rainfall events within each season rather than across the year itself. I'm just kind of curious why you split it up by split up the extreme rainfall events within the season and not just across the entire year.
Did you hear that, Becky?
Yes, I did. Yeah, so we looked at season and rainfall in separate models. So our heavy rainfall event models were looking across the full study period, not necessarily separated by season.
Thank you. Next presenter is Kondwani. Let's see if I can pronounce correctly. Let's try. Chidziwisano.
Maybe
60%. Okay, I tried hardly. WaSH in Early Childhood Development Centers Compliance Practice and Barriers in Malawi. Let's see where is the presentation. Let's see which one here. This one. Okay. Yep, correct.
All right, thanks very much. I will make a presentation regarding compliance practice and the barriers concerning the early childhood development centers in Malawi. Firstly, just want to give an overview that we all know that diarrhea remains a problem globally, especially among the children. And Malawi is not spared, where we're talking of about 22% prevalence rate of this disease affecting the children. And because of that, we have seen a lot of efforts trying to reduce further spread of the disease. But most of the interventions have happened at household level, okay? But there's a need to even understand other settings because kids are not only found at household level, but they're also present in other settings. That's really important. So because of that, we had to go further to check, to conduct the study in the early childhood development centers, and these are like the kindergartens, where children spend most of their time. And in Malawi, we are talking of about 54% of children between 2 to 5 years attending the kindergartens, or the ECDCs in short. These ECDCs normally, they provide meals to the children in form of porridge on a daily basis. And I should say that they operate maybe mainly in the morning hours. That's when they operate. And they have different providers of the meals in those settings. So why did we do this study? As I've already said, children spend most of their time in the ECDCs. And you will agree with me that a lot of research that has been done in the school setting has really focused quite a lot in the primary schools, neglecting the ECDCs. And yet the ECDCs is where the young children are also spending most of their time, and the young children are more vulnerable than even those that are going to primary schools. So this is an important setting also to consider in our work. And some preliminary work have identified WaSH being a challenge in the ECDCs, and because of that, it requires further attention in terms of trying to understand what is really happening in the ECDCs and what can we do maybe to improve the situation the purpose is to track down the transmission pathway of all these contaminants. So that's quite important also to explore. So with this background, we did a study, or we are doing a study, and the purpose is to develop and test an ECDC-based intervention, which we have divided it into three main categories. The first phase is like a formative phase, trying to understand the behaviors and the behavior determinants of practices happening in the ECDCs. With the use of that information, we need to design in an intervention and then try this particular intervention in an intervention trial. And the period is 3 years. So we started the work in 2024, and we likely will finish by the end of 2026. I should say that in this presentation, I will focus quite a lot on the formative research findings, because that's what I have for now. And this will focus much on the practices, talking of the barriers, the motives, as well as compliance with the guidelines that are existing in Malawi. And the overall reason is, if all goes well, we want to come up with an intervention that has an impact in terms of evidence-based intervention that should reduce diarrhea and improve child health and well-being while they are in the ECDC setting. That's the main reason. So in terms of the behaviors of interest, we have divided them into three. We have food hygiene, hand hygiene, as well as environmental hygiene. So these are the areas of interest in this study. And for the formative research, mainly, it was guided by the COMB model of behavior change. As we have seen from the topic, we want to understand the behaviors and the behavior determinants. So we decided that we should use the COMB to really drive understanding of these key issues. And we targeted 30 ECDCs in Blantyre district, which is a commercial district. So we spread our sample into urban, peri-urban, and also rural locations of this particular district. So quickly, let me take you through the findings of the formative research. Firstly, in terms of water supply, we noted that access to safe water is much better in the ECDCs. As you can see, generally they're accessing their water from safe water points, the boreholes and the piped water supply, which is very good. In terms of water treatment, we noted there was a big variation for urban, sub-urban, and rural, and mostly they use the water dispensers with chlorine, but not all of them were working. Sometimes you could see that the learners were even praying on the water dispenser, on the chlorine dispenser, because it's not functioning properly, but the dispenser is there. So sometimes it affects water treatment process. In terms of the potential sources of contamination for drinking water, we noted a number of issues. Firstly, the utensils, as you can see, or I should say in general, the process of drinking water is somehow compromised. They're accessing water from a safe water point, but there's sharing of cup, touching of inside of the cup, trying to clean, and then that can also increase the contamination. So we don't need to look at the source only, but what the practices that are happening within the process of drinking the water is quite important. So we said that in terms of COMB, really these are social opportunity, automatic motivation, also issues to do with the psychological capabilities being played here. Quite important if we are moving into or designing of an intervention. The same applies to physical opportunity. So you see that the school or the ECDC really has infrastructure in place, but is this infrastructure appropriate? You see that, for instance, here the cup, it doesn't have a handle. Someone is to drink the water from this particular bucket, will dip, and then there's a high chance of touching the water as well. So all this increases the chances of contamination. In terms of sanitation, we noted that there was variation in terms of type of toilets across urban, rural, and peri-urban. But we noted slightly improved toilets within the urban, and there was this behavior of smearing of feces on the walls, maybe because of lack of anal cleansing materials in the schools. and the open defecation was observed, especially in the rural areas. So in terms of potential sources of contamination, open defecation will be one of the challenges. Poor toilet conditions in terms of cleanliness and the infrastructure. And for behavioral factors, we're talking of physical opportunities like having proper infrastructure. An example is the toilet that is over there, which is a great risk for learners to use, and that forces learners to practice open defecation. Mind you, these are very young children. But also cleanliness here, something to do with effective motivation. Do they plan to make sure that they clean and they take care of the toilets? Is another issue that we also observed. In terms of hand washing, we noted that mainly urban schools had more hand washing facilities. So out of the 10 we visited, 8 had hand washing facilities in form of a bucket with a tap. But availability of soap remained a challenge because it's only a few hand washing facilities that had soap and water present. And likely that also affected proper hand washing. Direct observations indicated that there was limited hand washing with soap across all these locations that we collected the data. In terms of the potential sources of contamination in relation to hand washing by dipping was quite common, like what you see here. So this increases chances of contamination among the kids, but also issues of hand washing without soap, as well as minimal intention to practice the behavior, which is to a certain extent is to do with maybe psychological capability or maybe social opportunity, something to do with the norms within these school settings. In terms of food hygiene, as I've already said, food is provided to the learners, and it is prepared right away in the school environment. So there are really two critical points here which are being done properly. Thorough cooking of the meals, that's quite good, but also meals being served immediately after cooking, so they don't really wait for a long time. So that minimizes chances of contamination within the school settings. But in terms of sources of contamination, we're looking at the washing of utensils with sand and soil, like what we see here, which is really a great risk. So use of, for example, poor storage of utensils, like what we see there on the middle, that increases chances of contamination. So that is to do with physical opportunities, but also the psychological capability and automatic motivation for the caregivers. Mainly, we were targeting mainly the caregivers because they have the responsibility to take care of these particular young children. But also, much of activities happening while the kids are eating. It was quite good to see that they are all eating with spoons. That's a great improvement because it wasn't like this in the past. But now there's a lot happening here. Like this one is touching the shoe, and then playing with the spoon. In the process, they keep on eating. All this increases chances of contamination. So quite important to understand this if we are now moving into the co-designing stage. How best can we improve such kind of practices? I should say that in 2022, the government of Malawi came up with national guidelines for WaSH for the ECDCs. So we wanted to check if the ECDCs are aware and they are using these particular guidelines. Unfortunately, 80% of the participants, these were the caregivers, the food handlers, those responsible for running the ECDCs, were not aware about these guidelines. So having a guideline is one thing, turning that guideline into practice is a different thing altogether. So that's really an important element also to consider. So with this, it's not surprising to see that compliance is not good, because we wanted to check how are they complying with the guidelines that are there. How will they comply if they don't know the existence of the guidelines? So you can see 65% scored poorly in terms of meeting the requirements according to what has been established in the guidelines. So really requires a lot of work in this particular area. So with these results, we're now moving into the next stage. We want to use this information to co-design intervention which want to include the tips approach, want to understand further, and then we should be developing together with the stakeholders how best can we improve this, considering the resources available, and then we'll move into trial implementation at the end. Finally, I would like to really appreciate the support that we are receiving from RGHI in this particular study. We appreciate so much, but also to our partners, London School of Hygiene as well as University of Strathclyde, for the support that and their guidance in the process of implementing the study. Thanks very much, and over.
Questions?
Yeah, Christine.
It's very interesting. Are you planning to do any microbiological testing of the water, of the food, of the hands?
Mm-hmm. Yeah, I think that's really an interesting area to consider. I should say that originally we did not plan to conduct any microbial analysis or assessment. The reason was we were saying that we already have a lot of information on literature about microbial issues regarding the school setting. But when we started observing what we have shared here, we said that no, I think for us to really track down the transmission pathway, we may need to add an element of microbial assessment. So we are still discussing, but so far at the moment, we have done we have collected some water samples, especially to track down the issue of water contamination in the process of drinking, and the results are still being analyzed. And we are also thinking of collecting more samples in relation to food and the eating environment. Maybe those could also be potential sources of contamination. So we are really considering doing that as well, though originally it wasn't in the plan. Thank you.
More questions?
I'm curious if you are looking at any of the effects of the intervention on like early childhood development outcomes themselves, or any like longitudinal sustained behavior change effects, like once kids transition from ECDCs into like primary school, for example.
So you mean the other behaviors other than the issues of WaSH, or how that translates into when they move into primary school?
Yeah, like still looking at the sustained effects of, I guess, WaSH practices.
Yeah, I should say that for now we're just focusing on looking at what can we do to improve their behaviors. In the broader study, we have included an element of including the households where the kids are coming from, so that they should be they should be talking to each other. And then that may also improve transitioning of these behaviors as they are moving into schools. So it's something that is also a component of this study, but today I just wanted to share with you results about the ECDCs themselves, because that's the primary purpose of the project. Yeah.
Okay. Thank you. So our third presenter didn't come. So we're going to jump for the fourth presenter, who is Lauren Broyles, correct? Okay. Household water insecurity predicts household food insecurity in a water-rich environment in the Bolivian Amazon. Which one is this? That's one.
Yes. Okay, thank you. Okay, good afternoon, everybody. My name is Lauren Broyles. I'm a postdoctoral scholar at Penn State in the Water Health and Nutrition Lab. I am on the job market, so if anybody knows of short or long-term opportunities, I would be excited to talk to you about them. I'm also really excited to share about our study where we looked at the relationship between water and food insecurity in the Bolivian Amazon. So, first of all, just acknowledging my co-authors and data collection team. We also have this study published in Science of the Total Environment late last year, so if anybody's interested in more details, you can check this out. So globally, about 28% of people experience any water insecurity, meaning that they don't have water at home available when needed, free from priority fecal contaminants, and about 30% of the global population experience severe food insecurity, meaning they've run out of food and have gone a day or more without eating. And we know household water and food insecurity co-occur, and a lot of this evidence, however, has come from areas where water is scarce. This work is contributing evidence of the relationship between water and food insecurity in an area that is water rich, the Amazon. So the Amazon touches 9 different countries, and here there's over 1,600 millimeters of rain every year, which is concentrated during the months of January to April. And so this seasonal rainfall influences annual flooding. This is associated with a severe annual flooding season, and this really drives seasonality between food and water insecurity. So our study site is with Chimani in Bolivia. And so in this area, we put together a framework of how our environmental variables interact with our social and structural factors to then how those influence water and food insecurity. And here we're looking at the relationship on water insecurity, on food insecurity. Theoretically, food insecurity could influence water insecurity given this endemic nature of the two, but here we're focusing specifically on the direction of water to food. And so thinking about our environmental factors here in Bolivia and the Amazon, so surface water, so if we think about that seasonal flooding, so food insecurity is lowest with this people in Bolivia right before the rains start. So this is when Chimani have been able to grow their food, process it, and have all of that available. And then food insecurity increases as the flood season, as the duration of it goes on. And so by the end of the flooding season, food insecurity is highest before they're able to grow more crops. Also, seasonal flooding can dilute fish catches, so that also reduces food access in this area. And then flooding can also damage agricultural crops. Flooding can damage water infrastructure as well. So then thinking about our precipitation variables, precipitation influences flooding, but also thinking about how precipitation influences growing crops and access to food. And then temperature is related to water and food insecurity, as we've seen heat stress linked to higher odds of dehydration. So there are a lot of environmental factors that relate to water and food insecurity, and if you're trying to think about how environmental factors relate to that, you need to be very careful about your context and how specific variables and seasonality in that area will relate to your outcomes. And so so environmental factors influence water and food insecurity, and then our structural factors as well. For example, villages that are closest to the nearest markets might be buffered from severe flooding effects, as food relief might be brought to those markets, and people who are closer to them get that before people who live farther from those markets. So that's one thing, and then also participation in agricultural employment can also increase money available to buy food. And so, so all of these factors influence water and food insecurity. And okay, and so water insecurity can then influence food insecurity. For example, reduced water access if there's less water available to prepare food and prepare less desirable quantities or nutritious food. That's one way that could really lead to that. If a water quality could also change the color of the food and just the appearance of it as well, so it's less desirable or less appetizing. And so there are lots of ways that water insecurity can influence food insecurity. So looking at how does water insecurity and food insecurity here with Chimani, how are they related? We tested this in 3 different ways. So first we used our household-based experiential scales, the household water insecurity experiences scale and household food insecurity and access scale, to test how water and food insecurity relate to each other. Then we tested how does water insecurity influence severe food insecurity, so looking at a higher severity of the relationship. And then we also examined how these associations change when using specific questions about water problems and prevalence of food insecurity. So how we evaluated the water situation with these households. So we conducted household surveys, we did water quality analyses, and within the household surveys, we evaluated their water source according to if it was a surface water source, unimproved source, or improved. And then we also included the question, did anyone in your household drink bad water? And we also asked about time for water collection. Thinking about our food situation, we used the household food insecurity access scale. We evaluated fish and meat consumption, and then we also looked at the particular question within the HY scale about if people changed what they ate due to water problems. So using linear regression analyses, we found, and then also including different controls, including water access, if anyone in the household drank bad water, water fetching times, different household factors related to education, household size. We found a strong and consistent correlation between household water insecurity and food insecurity, where food insecurity increased by 0.47 points for every increase in the water insecurity score. Using logistic regression analyses, we see that increase in household water insecurity was associated with 43% higher odds of severe food insecurity. And then we also took out our household water insecurity score, and we replaced it with just one question from the HY scale asking about, did anybody change what was eaten due to water problems? And so with this, we see that if people did change what was eaten due to water problems, they had on average 2.33 higher points of food insecurity. That's our figure on the left here. And then we added the variable, did anybody drink water that looked, tasted, or smelled bad? And we see consistent results there, that if people changed what they ate due to water problems, that was correlated with higher food insecurity. So in conclusion, we see strong and consistent results that water insecurity influences food insecurity in this area. And although we did not explicitly test all aspects of our conceptual model, we did explore specifically the domains related to water access, water safety, and then we also incorporated time for water collection. And so thinking about these subdomains of water insecurity, that's just a really important piece of context here as we think about the relationship between water and food insecurity. In a different context, another domain about water insecurity might dominate in terms of the relationship. For example, water affordability. We didn't test that here, but in a different context, that might be driving food insecurity if, for example, purchasing water could lead to just less water or less money available to purchase food in the home. So really thinking about what is driving that relationship is important. And then we did look at if households had improved water access, how did that relate? And we saw a stronger relationship where households with improved water access had lower food insecurity. I didn't share that result, but that's in the paper. And so we see that perhaps in this context, pursuing improved water interventions could both help improve water quality at the home, but then simultaneously address food insecurity. So we see opportunities for interventions that can address both. And then one other important contextual piece is this data was collected during the lean season. So I talked a lot about the seasonal flooding in this area in Bolivia and how food insecurity is low right before flooding starts, but then really high after the flooding season is over. So our data collection happened at the end of that flooding season where food insecurity was really high. So it would be really interesting to know if we did data collection at the right before the flooding happened, how would that influence the water and food insecurity relationship when food insecurity would be perhaps or expected to be lower. So thinking about that seasonally is important. And so so again, overall we see a really strong relationship between water and food insecurity here in the Bolivian Amazon. Lots of factors contributing to that contextually, and thank you. And then if you're around tomorrow, there's another presentation from our lab at Penn State, Leslie's presentation at 3:15 in Dogwood. So thank you.
Questions?
You talked about how there could be an argument for food insecurity also causing water insecurity.
Mm-hmm.
So I'm just curious to hear more about like what that theoretical or what that argument might be. And then also, did you do anything in your analysis to like control for that potential reverse causality?
Mm-hmm. Thank you for that question. So talking about addressing the second half of your question first, we didn't control for that reverse direction. That would be a different research question or a different kind of analysis, and that was just outside the scope of what we did. But to do that, you would reverse, like put food insecurity as your put water insecurity as your outcome, food insecurity as a predictor, and then think about what kind of controls would, I don't know, if you need to change your controls that you include in your model at all. So there definitely are ways to test that. And then in terms of how food insecurity could influence water insecurity the other way, I'm trying to think of a really good example that's easy. So if maybe my first one that I'm trying to think of on right now is, so if in the situation of like an extreme weather event, for example, reducing or like flooding affecting crops, then there could be less food available to consume if people are employed in agricultural labor, then just like less money or income at the home. And so a lot of times when that happens, then food prices also increase. And so if there's I'm thinking kind of about that food affordability piece of that. And so if there's just less money available, food is less affordable, and then if people are perhaps having to also purchase water, then there would be a trade-off there. So that would be one.
Questions? Okay, thank you. So first I'd like to apologize to Rossanie. I didn't see that she was here, so she's here. So she's going to honor us with her presentation. So we're going to have the honor to watch her. So where's yours here? Rossanie, Malolo. Okay. So the presentation will be a global scoping review of water, sanitation, hygiene interventions for adolescents. So I'll show.
Good afternoon, you all. My name is Rossanie Malolo, a PhD student from Malawi University of Business and Applied Sciences. I'll share with you our findings from a global scoping review of existing water, sanitation, and hygiene interventions for adolescents. This is just part of our broad study, which is being implemented by a global healthy research group on improving adolescent health and well-being in Malawi. So this is a collaboration between a number of universities, University of Strathclyde, MOBAS, Kamuzu University of Health Sciences, and with funding from the National Institute of Healthcare and Research. The main aim of the bigger study is to understand factors, various factors which affect adolescent health and well-being, including social, political, as well as geographical context factors. And would want to explore what interventions as well as policies would support this. And largely, it's also focusing on the role of WaSH on these adolescents, as well as adverse childhood events which affect these adolescents. So the focus of the scoping review, which I'm sharing with you, is just on WaSH itself. Just to take you through the background, globally, the population for adolescents is high. They constitute about 16%. That may look small, but if we go into different regions, it's actually more than that. For example, in Africa, it's about over 30%. So we can see that that's high. And if we go down to Malawi, the population of young people, it's about half those who are under 18. So we can see that it's a large group which also needs attention. This is a very critical stage, the 10 to 19 years. There are a lot of developmental changes which are happening in them. But as much as it is like that, they often receive less attention in terms of health as well as WaSH interventions. Focusing on WaSH itself, we all know that inadequate access to WaSH has various significant impacts in terms of health, economic, as well as social impacts. So definitely this will impact adolescents, not only in their development, but also in decision making, as well as opportunities across their life course. So this scoping review aimed at mapping existing evidence on existing adolescent WaSH interventions with the aim of guiding the interventions which we are to design as well as to implement. And specific objectives included to identify and describe the types and components of existing adolescent targeted WaSH interventions. We also wanted to know the level of adolescent participation in these interventions, considering that participation is key in interventions, in success of interventions. We also looked at the reported effectiveness of the adolescent targeted interventions which are out there in literature. How did we do it? So we used the Accent Omare framework, which is a methodological framework on how we can conduct scoping reviews. It has 6 stages, which start from identifying the research question, and it ends with consultation exercise. So here at UNC, this is one of the, we are consulting, so your feedback will be very important as we are close to publishing this paper. In terms of participation, to measure it, we use the Shears Pathways to Participation. It's a model which supports adults working with children on how they can work with children, but it also provides an opportunity for measuring participation. It has 5 levels, starting from level 1, where you just listen to children. But the minimum recommended, it's level 3, where children's views are taken into account. So you don't just listen to them, but what they say, it's also considered in the interventions. And level 5, which is considered the above level, is where children share power and responsibility for decision making. So adults don't just make decisions, but they also include voices from young people. In terms of the eligibility criteria for studies which were reviewed, so included those which were original research reporting on WaSH interventions from anywhere around the world, and also those which were targeting females or males aged 10 to 19 years old and were published in English between the year 2013 and 2023, considering that at least 10 years would give us a good picture of what's out there. In terms of how we did the search, so we searched in 3 electronic databases, Scopus, PubMed, Research for Life, and one unique string was used in the search. How did we come up with the 70 eligible studies? So we went through that process where now we identified about 5,432 articles from the 3 databases, and we went through the screening, a number of screening stages, as well as the eligibility itself, and we identified 70 studies which were eligible for this review. So I'll share with you the overview of those 70 eligible studies. All of them which we reviewed were experimental studies. They were either maybe randomized control trials, before and after trials, among other types of experimental studies. In terms of geographical concentration, a majority of them, about 69%, were conducted in Asia, specifically in South, West, and Southeast. In Africa, there were just a few, about 29. In Malawi, we did not find one, which could be maybe an issue that publications on interventions are not there, but I think that's already an indication on how this group is being neglected. We also, in terms of either they are being implemented in urban or rural areas, so majority, which is 36%, are being implemented in urban areas. The rest are either in both urban and rural, and others are just focused on rural areas only. Now on targeting, the expectation was that maybe a lot of studies would consider or are targeting adolescents only, but only 3% of the studies targeted adolescents only. The rest, about over 50%, were included young people children under the age of 10, and the others, they include people or young people from 19 years old going up. In terms of the context also where they are being implemented, schools or households, majority are being implemented in schools, taking the opportunity of the existing structures which are there. And in terms of gender, majority were targeting both genders, and 78% of the interventions were implemented in less than a year. And also only 18 included adolescents with the disabilities. That's 18% of the eligible studies. In terms of the focus of the interventions, we observed that the standalone interventions were more common than full WaSH packages. So there were a few studies which were implementing all the components, either combining WaSH, the hygiene component, as well as the sanitation. Mostly were just maybe hygiene, or maybe sanitation only, or water supply. And in terms of hygiene, majority were on oral hygiene, menstrual hygiene management, hand hygiene, as well as the personal hygiene. Looking at also how they are promoting, or how they, in terms of the intervention types, we looked at whether they were behavior change and communication interventions, or maybe they are integrated, or maybe they're infrastructure only, or they are just combining two of these components. We observed that those which were integrating were only 33%, so it means that they included infrastructure, they also included behavior change communication, as well as education, where they're providing information or knowledge. Only a few targeted infrastructure only, and 61% focused on behavior change and communication, combining with education. We did not find studies which maybe were just focusing on information only, or maybe information and infrastructure. That's why we can see these percentages. In terms of effectiveness and participation of adolescents in this intervention, majority of studies were reported to be effective. So about 70% of the studies, they achieved their primary outcomes. But let's bear in mind that these primary outcomes mostly were based on reported versus maybe observed, or maybe conducting various tests. So that's where the effectiveness in this study is coming from. And 21% were partially effective, with 9% being not effective. In terms of participation, majority of the studies, about 84.3%, were in level 2, where children are supported in expressing their views. So they were just given opportunities to provide information. Maybe they are given an opportunity to do photo voice or maybe storytelling just to get their voice. But if we look at level 3, which is minimum recommended, according to this framework, children's views were not really taken into account. There are only a few studies where they were doing co-designing with them and taking their inputs. So we can see that participation here is very, very low. And none of the studies reached even to level 5, where decisions are shared between adults and young people. We went further just to look at maybe if there was some potential relationship between participation and the effectiveness of the interventions. So we just observed here that all studies which were in level 4, all of them were also deemed effective, showing that there is potential of participation promoting effectiveness of interventions. What key gaps did we observe from this scoping review? So the first one is that there is limited geographic reach. So WaSH interventions are concentrated in Asia, other regions being underrepresented, like Africa, as I mentioned, where the population is also high. Of course, we can't compare with other continents as well, but the vulnerability is also high. So we need to consider this as well. There's also an inclusion gap. WaSH interventions are rarely reaching adolescents who are out of school. As I mentioned, that majority are in school just because implementers or adults are taking advantage of already existing structures to support implementation. But we are leaving behind a large group, because if we look globally, 1 out of 5 adolescents are out of school. So how are we supporting those ones? And also in terms of the inclusion gap, adolescents with disabilities are left behind. There's also limited integration of WaSH with related sectors such as oral health as well as nutrition. And adolescent-focused WaSH interventions, they are emphasizing knowledge, behavior change communication, but they are lacking adequate water and sanitation infrastructure support. And lastly, participation of adolescents in designing and delivering WaSH interventions is very limited and may definitely impact effectiveness of interventions. And there's also need to further understand what meaningful participation is and looks like in this context. So for more information, you can follow us on this by scanning these QR codes. And beyond that, be expectant for this paper. Thank you very much.
So my first question is about the effectiveness of interventions, given only maybe one study only looked at adolescents, purely adolescents. So when you talk about something, achieving a primary outcome, is there any way to disaggregate the data to say within this age group, even if the larger sample was, 18-year-olds to, 100, right? But is the effectiveness for the entire sample, not just for adolescents? Am I accurate with that?
Okay, so the effectiveness mostly was just based on their primary outcomes.
Right.
And that would be challenging because most of the studies were not expressing on how maybe each group which is being engaged, it's maybe they have these indicators targeting them, or how they are engaged in that particular intervention.
So that was sort of my assumption, which I think is sort of interesting too, to be effective, for which age group even within that, right? And I guess so. My other question is more broadly, if you're looking at the studies, I'm just curious as to how, if at all, the researchers are even thinking about integrating knowledge of human development into interventions and research. I'm just very curious what your thoughts are on that.
I think that should already show maybe the lack of attention that we haven't given to adolescents, considering that it's an age group where there are a lot of developmental processes happening, biological and social. So I think this study provides us with an opportunity to look at that, because I mentioned that we are looking at social, emotional, there are a number of factors which are looking at. So maybe our study will provide a response to that. I don't know if I've responded to your question.
Yeah, no, but I guess because, yeah, it's like you can't say a 15-year-old is just like a little adult, right? Right. And are people acknowledging or thinking about that when we're designing interventions, right?
Any other questions?
Thanks for a great presentation. I was wondering what sectors or other school-based interventions you think are most useful for integration of social sciences.
Okay, on that one, I think the ones I've mentioned of oral health as well as nutrition, at least those which are known and common. But I'm glad that before this session, I went into another session which was talking about hygiene integrating into others. So there they mentioned about integrating hygiene into MCDs, integrating maybe hygiene into mass drug administration. So those are some of them which integration between WaSH can happen. But also in sexual reproductive health, that one is already a direct link because it lays like a foundation already. If we are to talk about MHM, definitely, if we are talking about before we even talk about other sexual reproductive issues, we would talk about MHM. So those I think are the potential ones, but others I think may also add to other potential integrations.
Okay, hold on. Well, I will still have a few minutes, and if someone has questions to the other participants, the other speakers too, so we can use this time for any other question that you want to ask before, but you were afraid to ask, so you can ask right now. So just raise a hand. Okay, no more questions, let's have some fun. Thank you. Well, I see your pictures here. When I look at my son who's 8 years old in the United States. My point is, of course it's important, but my point is, it's no different because they're kids. That's my point. They will do that. They're not going to follow guidelines.
Stuff is with other defined and she was like, oh no, we're taking it. Are you 4-year-old sleeping for that? Of course.
Look, I'll give an example. This is the part of my life where I get sick more often because my kids are school age. So they go to school, they get sick, it has to be. Here, I say, no. So, very interesting.
Good job, guys. All right, photo. I'm bringing it. I'm like, come on. Remember what your slides back. Come on. I know. That's why I almost started going. Oh my God, you look so formal. The three of you like pretend like each other. Ready? 1, 2, 3. I know. Good job, guys. All right, only Mindy left. But they went without me. And I was like, I'm not going to milk guys. But I had every confidence after her practice this morning, which was beautiful. I had no worries apart from the guy who didn't exist. We didn't like you to go on absent.
I think she was playing some magic.
She went. So he just assumed, but she was like, I think there's work to do. Right, I was gone a lot. She's invisible.
Maybe she was playing magic so that she could.
Was that exposed to someone who checks her slides there? Alright, I think I'm a lot to live up to tomorrow night, dudes.
And so they go back to
What did you do last night? Sorry, I just kind of wandered out. I didn't think about it. I was like, she was so tired yesterday. She was practically incoherent. I was like, is there anyone there? Oh yeah, you know, I work the whole, sorry. 9 to 5. Because it takes about an hour at this time of night. God knows what security I will or won't find at the airport.
You're like done going
Yeah.
to the airport?
and has looked at separate.
Yeah, so I've got time to pack a bit.
And then
I'm winning. You will not
yeah, Tom had told me to like ask her how the paper is doing. Oh, really? Because I guess they have sending us for the Irish
Which like it's not the end.
yeah, want to pay. And he was saying they had actually like meaningful collaboration with their first class, who was hired in the community with her. And so I'm sure she's just busy, but I've heard this kind of story set, I'm sure. But he's very busy. He's working on same thing. Yeah. Okay.
I mean, to be fair, Tom's working on the show.
Exactly. I mean, I'm not gonna lie, I'm
Just
gonna
like, and
like when.
I was not at all, like, crops is
Because
the,
right now, I think I'm just
like, they had done this whole evaluation of property costs is monitoring program in like
some of these
2012 or something like that. And maybe that was where the partnership started and I was not involved in that, like, but in terms of crops, like, Kevin was around.
Oh, really?
Yeah.
I didn't realize
I
he was
met,
around so
there you go,
recently.
yeah,
Oh, okay.
I have met him.
Okay.
Yeah.
And we're good to know. Good to know the history. Yeah, maybe I'll try to connect with him. I mean, Tom said he even like had a lecture there, and he said the students were just zero presenters.
Yeah, well, that was like the first, one of the first times I went to OSHA, he went to XIM, and everyone was like, oh, dude, I guess he must have, he said very last minute, like, do you mind just like talking through it in one of my classes? So we were like, that's fine. And so Sheila and I both like scrambled to put some slides together. I don't think Tom was on that trip. And we show up, have you heard this story?
No.
We like showed up to the XIM campus and there were, I have pictures somewhere, I would take it off, but like banners, massive banners of our headshots.
Get out. Like, did you take them home? I hope they're not in your house.
No, I'm telling you, it'd be too big. Like, it was like taller than my ceiling in my house.
Oh, I would be horrified. Yeah.
Both like at the gate of the university, like as you come in, so like anyone passing by could see, and then also outside the building where we like went in and lectured.
That is
I'm
hilarious.
excited for the day.
It was, and he like gave us gifts, and we were like sitting on the stage in a panel, and I was like, this is not.
What we expected.
No. And we got back and I was like, oh my God, Tom, you'll never believe. And he was like, well, I hate to break it to you, but that happens to me every time. I was like, I didn't think I was special. Like, right, like I didn't want that. That's very bizarre.
Oh my goodness. Well, I'm glad I didn't experience that.
They always, I feel like, yeah, the conversations were always like, you know, we really want our students to work with you guys, and we would always be like, okay, great, and then there would be zero follow-up on their end, yeah.
Well, the presentation, I mean, no, we really think we need the data is significant. I did.
We're exceeding every parameter.
Wait, you may have answered, don't.
Which is, like, we need to be treating the water. We're gonna try to roll this out. So,